ये मैंने दो डाल दिए एक्चुअली इसमें। हम्म, ओ, क्या है क्या started? Okay, good morning, each and every one of you. Today we are going to start with a very important topic, and that is a congenital problem. And its name previously was a congenital dislocation of the hip because it was considered that the aberration or the fault is during the gestational period. But later on, it was found that at the time of the labor or at the time of the birth, the hip may be normal, but later on, as the development progresses for the hip till the age of 10 years, there may be a error in the normal development of the hip, and that is why it was named as the developmental dysplasia of the hip. So today we are going to see what the developmental dysplasia of the hip is. So the developmental dysplasia of the hip is nothing but the instability of the hip in the newborn, which includes the dislocatable hip at the time of the birth. If you test or if you examine, you are able to a normally located head into a dislocated position. That is, you are doing a dislocation, and that's why you are calling it as dislocatable hips. Then we have got acicular dysplasia. At the time of birth, there is already an existing acetabular dysplasia. Then you have got a subluxation of the femoral head, where the dislocation is not complete, but there is a partial contact of the femoral head within the acetabular cavity or cup. And the other variety is the dislocated femoral head. So in the last variety, the head is already outside the acetabulum at the time of birth. When you examine the immediate post-natal period, in that you will find that the head is already outside the scapulum cavity, and that's why these includes these kinds of instabilities of the hip is defined as the developmental dysplasia of the hip, which was previously known as the congenital dislocation of the hip. And as the child grows, it may progress to dislocation or a poor acetabular coverage in a case where we were doing a dislocation by our own pressure, and that was covered under the topic of or under the head of the dislocatable hips. So in the dislocatable hip, the progress to the dislocation or poor acetabular coverage. Then there may be secondary changes due to the dislocation within the head and in the acetabulum. So the process is not restricted to one point of time, that is in the congenital abnormalities of the hip, but it includes some hips that were normal at the time of the birth and subsequently became abnormal. So you can see here in the figures that one head is looking to be normal and almost is congruent with the acetabular cavity. In the second, you have a dysplastic hip where the slope of the acetabulum is very shallow, is not deep enough to cover the whole of the articular surface of the jaw of the femoral head. And in the dislocated hip, you can see this is the vestibular cavity, and the head is just lying outside the acetabulum. So this is the thing. Then you have got certain lines which call which speaks of the dislocation at a time of the time of examination, maybe in the immediate neonatal, immediate post-labor period, or after some time. And in these, there are two tests which are called as the positive Barlow's test or auto-Lenny test. In the Barlow's test, you are examining a case of query DDH, and when you examine the hip and with a single small pressure on the anterior side of the hip through your thumb, you are able to take out the head of the femur outside the acetabular cavity, and this is called the positive Barlow's sign. And in this, you will see that the hip is dislocatable, is not dislocated already. But in the other case where you do a reverse of the Barlow's test, you try to push the head inside the acetabulum, doing an internal rotation and anteromedial pressure from the back. And that is how you are able to relocate or reduce the dislocated, already dislocated hip into acetabular cavity. Then on the X-ray, you have got the acetabular index, which speaks of the shallowness or the deepness of the acetabulum, and the lateral displacement of the femoral head is by the Perkins line, which is a perpendicular line dropped from the anterior superior iliac spine. So usually there are four quadrants, two line, one line, the line which is joining the striatal cartilage of the two joints, which is horizontal, and the Perkins line, which is dropping from the anterior spine, and usually the head of the femur remains in the infromedial quadrant, but where the acetabulum is shallow, and the circular index is high, the and the teardrop is bigger. There is a distance from the teardrop to the femoral proximal metaphyseal area, and the head is in the superior and outer quadrant. So these are the few things which you can detect on the X-ray. Then you have got a radiograph finding in which you can see the increased obliquity of the acetabulum. As I said, the 2 points of the acetabulum they are joined, and a line is drawn which speaks of the slopeness of the acetabulum. Then you know the sentence line or intact sentence line, which is a parabolic line from the inferior margin of the neck of the femur and the obturator foramina. And so these two curves, they together form the sentence line. And when it is broken, it is the center line is broken, is one of the indicator or indicates towards the uh, dislocation of the hip. A femoral head is not fully intact with the is in contact with the acetabulum in cases of the subluxation, but there is some amount of contact remaining, is not completely out of the acetabulum. Okay, then you have got a reduced CE angle, and there is a break in the center line, and the widened teardrop, that is the femoral head distance from the teardrop, and you have got certain dysplastic changes in the acetabulum. Then you have got femoral head not in contact with the acetabulum, and that is the dislocation. And in this, you may find dysplastic changes within the acetabulum. As you can see on the right side, the acetabulum is shallow as compared to the right side. Sorry. Then the dislocation or DDH can be teratologic or it may be anterior dislocations. So fixed dislocation at birth with limited range of motion at the hip. During the gestation, the hip is at risk for the dislocation. During the 12th week, when the lower limb rotates medially, and during the 18th week, as the hip muscle develops, dislocations during these developmental stages are termed teratologic. That means the child is still in the womb and has not been delivered yet, and are the result of the congenital abnormal neuromuscular development of the child's muscle and neurology. So that in this, usually the treatment is unsuccessful and close reduction is not successful, and you may have to go for open reduction at 6 months of age. Initial 6 months, you can try all the non-operative methods like using the different kinds of braces, Paulic harness, and so on and so forth. Strictly speaking, the DTH applies to the idiopathic hip dysplasia, right? Then there are secondary hip dysplasia, which are neurological in nature, like myelomeningocele and cerebral palsy. They do have secondary hip dysplasia. Then you have got connective tissue disease, like Ehlers-Danlos syndrome. Then you have a myopathic disorder, which can also give rise to the secondary hip dysplasia, especially in the arthrogryposis multiplexa congenita, where you have got all the muscles they are going to become the fibrotic. Then we come to the etiopathogenesis of the DDH. And so first we talk of the incidence. So the risk factor associated with the DDH are, that is the four F's. Number one, the female child, the firstborn child, the foot first, that is the breech presentation, and there is a positive family history. So these four F's are very important, and almost when these four F's are present together in one particular child, this the child is very much prone for the development of the DTH. And the position, intrauterine crowding, metatarsal adductors, torticollis, conjugal dislocation of the knee, and oligohydramnios, they all are the associated things which are present in few, may or may not be present in one or the other child. But a common occurrence of all these or one of these is possible in a DTH patient. So the left is more commonly involved than the bilateral hip, and the right is less involved in that case. So this is the rate of incidence left more than bilateral, and the rare is the right hip. Then the breech delivery, the frank delivery, the incidence rate is too high, and this is the 1/5 load of the all the DTH is because of the breech presentation, and that is what we call the foot first. So when the child is delivered, the foot is coming first. Then you have got a breech infants, the Laurie et al. They showed that the breech infants delivered by elective cesarean section, pre-labor, had a lower incidence of the DDH than those breech babies delivered vaginally or normal birth canal route. Then you have got complete or a footling breech, the lower incidence of DDH. When there is a complete or footling breech, the incidence is 2% only, right? Then we go on to the associated condition. The other positional abnormalities include the torticollis, as we discussed earlier. Then you have got metatarsal adductors, which is 10% association, positional club foot because of the crowding of the things in the womb, the position can lead to the positional club foot. Then you have got a congenital knee dislocation because of the excessive pressure within the uterus. Then you have got the different theories being given, and one theory is the mechanical factor, The other says the hormone-induced ligamentous laxity. A relaxin hormone is released when the female or the male or the mother is pregnant. Then at the time of the delivery or when the gestational period is over, that is about 9 months, then the hormone is released to relax the pelvic ligaments, and those are the presumption or assumptive theory is that this ligament is this hormone is responsible for the relaxation of the ligament in the child also and causing the dislocation of the hip, and mechanical factor because of the breech when delivery there is too much of pressure within the womb and can lead to the dislocation of the hip prior to the delivery, and this can cause a secondary changes, and then once the secondary changes develops and later on it doesn't go inside the acetabulum, and when the child is delivered you examine and you find that it is the dislocated hip. So that is the because of the mechanical pressure. Then there are certain child who have got a positive family history of the dysplasia of the acetabulum. In those cases, there is a primary acetabular dysplasia. The hip or the acetabular cavity is not fully developed at the time of birth, and the pressure caused by the head on the acetabulum is not there, and it is this plastic from the very beginning, from the day zero of birth. Then you have got genetic inheritance. Certain people are drawn because of their genetic inheritance. Then we go on to the clinical detection of the DDH, and the examination is common for birth to 6 months of age, and you have got asymmetrical thighs, thigh folds. If you can see in this case, there are more creases on the left side of the child as compared to the right one, and this is indicative of abnormal hip, which is also see these creases are also seen in the normal hips, but not asymmetry of the thigh folds of the creases. Then you have got a widened perineum and the prominent graded trochanter. The graded trochanter on the left side is more prominent than on the left side. Then we go on to the another sign, and it is the Galeazzi's sign, and also known as the Alice sign. In this, when the child is sleeping supine and the infant is sleeping supine, and when you keep the hip at 90 degree and flex the knee to fully, the both the knee and the foot are touching the ground, and you find that the level of the knee from the ground is different for two sides if there is a dislocation of the or the dysplasia of the hip. And as you can see in this picture, this left side picture is showing the right hip, the right knee is lower and the left one is higher, and this shows that there is a discrepancy of the level of the knee. But beware of a situation where bilateral hip abnormality is present and this symmetry may not be present. Then you have got autologous sign, as we talked earlier. The child is already having a dislocation, and you hold the thigh, both the thigh of the child, with your thumb on the anterior aspect of the thigh and the four fingers on the back of the thigh, and you try to reduce or take out the hip joint or head of the femur, and you will see that it is already there, and when you push it from the back with the abduction and internal rotation, you find that the hip goes inside, the head goes inside, and this is a positive orthogonal sign. Hold the knee and abduct the hip while lifting up the on the greater trochanter. A positive stress is the feeling the dislocated hip gives a clunk, a kind of sound when the head goes inside the acetabular. This popping sound is the positive orthogonal sign. And then you have Barlow's provocative test. In this, you are provoking the hip to get dislocated. And this is possible where the variety of child is a dislocatable hip. That means there is some kind of ligament laxity or the acetabular dysplasia is already there. The stability is not there. When you are putting a pressure, the hip is getting dislocated. The head is going out, as you can see in this picture. Okay, so in this you have to adduct and push the posteriorly on the tip, on the hip, as you have holded the child's thigh with both the thumb on the front of the both hips and the four fingers on the back side, and push the hip on the posterior side while you are adducting the hip or the leg. A positive sign is a feeling the hip pushed out of the sternum. It gives you a feeling that something is giving way, and that is called the positive Barlow sign. And then you have got Klinsky sign, that is bilateral DTH. So ortholanies and Barlow's manual are the ministry of the clinical diagnosis in the first month of the life. Even in the best hands, the physical examination can fail to detect the DTH, and after 3 months of age, the autonomy and the Barlow's test become negative due to progressive soft tissue contracture. Then, sorry for the disturbance. Then the older child, you have what the abduction becomes more limited, which is particularly noticeable when there is a unilateral disease. A femoral shortening, that is the positive Galeazzi or Ellis test, may be the apparent, but this can be difficult to appreciate with the bilateral disease, as we have said earlier. So ambulatory children which have a will have a Trendelenburg gait in addition to the limited hip abduction, and you have got a Trendelenburg sign positive. As you already know what is Trendelenburg sign, then you have got telescoping positive when you push the knee of one side with the child in the spine position and the other hand on the hip area. You can feel that the head is touching your other hand. For example, if you are examining the right hip of the child, and you are putting your left hand on the posteromedial aspect of the child's hip, and you are pushing the right knee with your right hand, you can feel the head is touching your left hand, and this is a positive telescopic sign. Then you have got exaggerated lumbar nodus when you put your flat hand on the spine position of the child under the lumbar area. Your hand is able to go inside the child's spine. Then, what is the natural history? In what are the stages through which it goes? So usually the child uh, becomes becomes symptomatic because of the painful hip, and the degenerative arthritis over time develops, and often the subluxation or the degeneration progresses. Hip with the acetabular index, which is more than 35 degrees, will likely to require a replacement later on when the child has achieved the adulthood. If these hips are well reduced after primary treatment of DTH with a greater than normal CE angle, the risk of the degenerative arthritis decreases. So the care of the child is important. Otherwise, the child will have a crippling problem of pain and an abnormal gait, which looks very ugly, and the child suffers. So, in the childhood and infancy, it should be treated and it should be detected rightly. And in the certain countries, not in India, we have got a screening program. All the deliveries has to be examined by the orthopedic surgeon. If not the orthopedic surgeon, at least by a pediatrician who is trained to examine the this common problem of DDH. So always lead to symptomatic digital arthritis if it is not treated or if not given care, and the rapid progression occurs, and you have got severe subluxation. The symptoms appear in the second stage. If it is moderate subluxation, the symptoms appear in the third to fourth decade, and then you have got if the mild subluxation, it may be tolerated by till the fifth or sixth decade. Then what happens to a completely dislocated hip? So symptoms much later than a subluxated hip and may never become painful because the head is already out, and with the pressure of the dislocated hip, falls acetabulum forms on the ella of the hip bone. Then what are the consequences of the persistent dysplasia? So number one, the abnormal gait. Then you have got restricted abduction. Then you have got a reduced strength. Then you have got increased rate of degenerative joint disease. And the outcome of the untreated unilateral DDH is less favorable compared to bilateral disease. Limb length discrepancy occurs, asymmetrical movement and the strength occurs, and the ipsilateral valgus knee also develops. The degenerative joint disease tends to present earlier in subluxated hips than in the dysplastic hips without the subluxation. Then, what is the what is the natural history after the 6 months of age? So over the age of 6 months, spontaneous resolution of the dysplasia is unlikely. Once the 6 months has gone after the birth, and if the problem is persisting, it is unlikely to go into correction. Older children I tend to have more advanced changes in the soft tissue and the bony structures. Then the changes in the acetabulum do occur, and ossification is delayed, and the acetabulum remains shallow and is more anteverted, and it is deficient anterolaterally. And then certain changes do occur in the head also, and what are those? And they are the delayed ossification of the nucleus of the primary center of ossification of the femoral head, and the anteversion becomes exaggerated because of the constant pressure by the blade of the or the ela of the hip bone. Then by the age of 16-year female with the long-standing missed left DDH, you can see how the pseudoacetabulum is forming on the left side, and there is a adduction contracture. The left femoral head articulates with the new acetabulum or pseudoacetabulum within the iliac bone, that is I call the ela of the ilium or the blade of the ilium, and the left femoral head shaft is reduced in diameter, that is smaller in size, and there is always a wasting of the thigh muscle because of the this particular problem. And this is, you can see on the right side, of this X-ray, a well-formed pseudoacetabulum with dislocated head is apparent and the limb looks to be externally rotated as compared to the left side. Then here we can see the excessive lordosis in a bilateral case. This the left and right both are dislocated, and now this child has achieved the adulthood, and there's a good amount of lordosis to compensate the gait abnormality. And in such cases of the bilateral DDH, you have a waddling gait. Then you go for certain kind of imaging, and the first one is the plane radiography, and in this you have got acetabular index when the center of the index is the or the angle of acetabular index is the center of the thyroid cartilage, and you draw a line which is joining the another center of thyroid cartilage of the other hip, and this is the Hill-Jenius line, and one particular perpendicular line to this which is cutting the anterior edge of the acetabulum, and this makes the bifurcation of the or the four quadrant, that is the anterolateral quadrant, superolateral quadrant, infralateral quadrant, and superomedial quadrant, and the inferior quadrant. And in the dislocated hip, the acetabular index is more, which is the line drawn from the center of the thyroid cartilage to the anterior edge of the acetabulum, and this forms the alpha angle of the acetabular index. Then the center line, which you can see, is continuous on the right side, and is formed by the inferior edge of the neck of the femur and the superior margin of the obturator foramina. Then you have got the acetabular index is what? An angle between the acetabulum and the Hill-Jenius line, as we said, and it should be less than 30 degrees in a newborn. If it is more, that means the acetabula is dysplastic. Then you have got CE angle, which cannot be measured until the ossific nucleus is apparent, because you need to have a center of the head of the femur. Normally it is 10 degrees in a child which is aging about 6 to 13 degrees. Then the ossification center of the head of the femur appears at the second or 7th month of age, and so it is difficult to know the position of the head of the femur in a child who is less than 6 months of age. Then by 8 months of age, you can see in this case the left acetabulum is shallow and hip is dislocated. The left proximal femoral ossification center is small compared with the normal right side. See this one, this is the one, and this is the one. If you compare the both, definitely and obviously the left one is smaller compared to the right side. The normal right side acetabulum has a central depression and a well-defined lateral edge. There is a central depression and a well-defined edge as compared to the left side, which is not well-defined edge of the acetabulum. The acetabular teardrop, this is a teardrop is developing on the right side, but not on the as on the this plastic left side. Then a very important tool for diagnosing the dysplasia is the ultrasound. As we said, the nucleus or the ossification center is not apparent till the age of 6 months from the birth. It is difficult to have a X-ray diagnosis of the DDH, but with the help of the ultrasound, USG, you can know the dislocation of the hip, and that is the alpha, beta, gamma, and lambda. Degrees are there of the dislocation on the scale of the Grafi's scale. Okay, and then there's a sonographic classification hip dysplasia, in which there are certain angles, and type 1, type 2, like this, you go up to type 6. Okay, which is not for you at this level of UG. Then you have got another method of diagnosing the dislocated hip through the arthrography. Arthrography is nothing but putting or infiltrating the radiographic dye within the joint cavity, and when you push the dye, there is a contrast X-ray available, but it is not routinely performed because now a better means of diagnosing the hip dislocations are available. But if it is either is performed before the surgery or intraoperatively, just to have a black and white evidence of the problem. The goal of the arthroscopy is, in DTH, is to demonstrate the position of the femoral head in the with respect to the joint structure both at rest and during the production of the stress maneuvers. It is also routine out. It is also outlines any deformities or obstruction to the concentric reduction. That means if there is something within the cavity of the acetabulum, that will also be delineated by putting the dye, which will be definitely having a radiolucency because of that particular a structure or a debris or anything there. And some of the things which can have within the acetabulum are the inverted limbus, the acetabulum rim cartilage, the edge becomes inverted because of the constant head pressure. Then you have capsular constriction because the child is trying to get the head inside, but all the time it is trying to push the head inside, and the capsule is getting stretched and getting constricted at the vertex of the head. Then you have got pulmonary hypertrophy. Whatever the tissue is within the base or the floor of the acetabulum, that hypertrophies, and that's called the pulvinar. Then you have got a hypertrophied ligamentum teres, the at the pit or at the center of the acetabulum, you have got a ligamentum teres, and that becomes hypertrophied because of the constant pull of the this is the orthographic picture. You have pushed the die, and there is a lot of things which can be seen in the picture, and arthrogram made after 15 days of overhead traction, showing the hip to be reduced, a square shaped limbus. A square shaped limbus, this is the limbus, this is limbus, this square shaped limbus. Arrow is at the superior pole of the epiphysis, and marked capsule distension are evident. Okay, so there is a then your CT of the hip can be done, and which also can tell you the hip is out. So in this X-ray, you can see the left femoral metaphysis is not aligned with the acetabulum, and the femoral head is displaced posteriorly. Previously, they were not available, but nowadays the CT and the MRI and so many things or the tools are available, and the detection becomes better, and has a little rise in the incidence rate is there because of the better detection of the DDH. So the distinct advantages over both the CT and the arthrography in the preoperative imaging in the patient with the DDH is the MRI. It is the ability to differentiate between the different types of the soft tissue, which enables the visualization of the unossified cartilage, ligaments, fats, muscle, and fluid, including those soft tissues that present on the obstruction to the concentric reduction, such as the pulvinar, the labrum, and the joint capsule. And the lack of ionizing radiation is good for the child. These are the advantages of the MRI. And MRI is more consuming than the CT or arthrography, and hence it needs to keep the patient calm, quiet. In the newborns, in the infant, sedation may be required, except if the patient are in a spica cast, since this limits the movement. That is one of the alternative to sedate the child. The main disadvantage of the MRI imaging is increased cost and the limited availability in the developing or the underdeveloped countries. Then, as I said, the screening, the general examination is done, and the plagiocephaly or stenomastoid tumor or feet for any congenital deformity is seen, and it is associated with the DTH, as one should have a point of examining the hip joint, because these three, four things are available, and which is usually a combination of these three, four things, and hence it points you towards the presence of the DDH. Then you have to do an examination of the hip joint, and those tests which are done are the Barlow's test, the Ortholen's test. Then you have got a limitation of the abduction. Then you have got a leg length discrepancy, and that is the Galley's sign or the Ellis sign, as we discussed earlier. Then you have got trifold symmetry, and you have got a limp in a Beijing child. These are the radiological indices which is of help, but of not much interest to the undergraduates. Then the clinical screening for all the unit of the for the hip instability is a must in the certain countries where the law fully compulsion to do the screening of the child for this kind of problem. Then the careful screening for the infant with the risk factors like the family history, Greek presentation, torticollis, matters adductors, and oligohydramnios, if they are present, it points towards the presence of the DDH. Then you have got a screen with the USG, as I said. Then you have got female infants which delivered by breech. Then you have got family history of the DDH. All these are the pointers for the DDH. Then what are the treatment? So treatment is divided into different categories. The first is the birth to 6 months, and the first one is the use of the Paulic harness, which is nothing but a kind of a strapping system which keeps the hip into a reduced position. So indications for the use of the Paulic harness are all dislocated hip that can be reduced by Ortolin sign positive. Start a Paulic harness at the time of the diagnosis. Do not neglect or avoid to use it. Hips that are located but can be subluxated, and it is the Barlow sign, or the hip is dislocatable on the day of examination, most probably on the day of the birth. So some may spontaneously stabilize and some may be dislocated. So there are two varieties in the dislocatable. Some may get dislocated, spontaneous reduction by the activity of the child, but in some it may remain dislocated, and you have to reduce it and use the or put the Paulic harness. and re-examine after a few weeks before you start the treatment. So you have to start the treatment after a few weeks. So hips that are normal on clinical examination but abnormal on USG, then you have to keep a close observation, go on as periodic or repeated or recurrent examination of the hip to detect that when it is getting dislocated. And you may have to go for a USG at every 6 months of age, every 6 weeks of age, so as to detect the dysplasia of the acetabulum. Then you have abnormal hips treated, then you have got graphies. Type 2 hips are more likely to improve without treatment than the graphs or graphies 3, 4 hips kind of hip dislocations on USG. Then the irreducible hips are there, which are not, you are not able to reduce the hip by the autologous manure or by growth reduction. And so these are the hips which are likely to fail if the initial coverage was less than 20%. And this is the application of the Paulick harness. This is how the steps are tied so as to keep the hip in the abduction of about in a safe zone of 30 degrees, external rotation and flexion at the hip and at the knee. And in this, the nursing of the child is comfortable and the child is also can sleep well in this position. Then you have to do a weekly follow-up during the hardness treatment and change of the size of the Paulick harness after 3 to 4 weeks. Then USG are done at the 1 month period. If it is untreated, you may have to discontinue the treatment because USG is there. Then you have to examine the child under the anesthesia. An arthrogram for cause of instability. If the hip is reduced but can be dislocated, then you have to continue the Paulick harness for another 3 to 6 weeks. So every week, every 3 weeks or 4 weeks, you examine, and if the dislocation is again occurring or is getting dislocated, then you have to continue for more than 6 months. Then after 6 weeks of harness, USG is done with the child out of the harness, without the harness, and if the head is reduced, then you may wean off the harness or you can discontinue the harness as the USG suggests that it is well contented within the acetabulum. Then you may have to do a X-ray at the 3 to 4 months of age. By that month, the small nucleus may have appeared, and then you have to do an X-ray at the 1 year of age. Then an annual follow-up is also important. Follow-up till skeletal maturity is also important because that asymmetric epiphyseal closure, vulgus abnormal femoral head, and the reduced coverage of the acetabular dysplasia in 20% of the cases do occur. Then what are the treatment after the 6 months of age up to the 18 months of age, and the reduced risk of the avascular necrosis in cases of the traction. The goal of treatment in cases of the older child are to obtain and maintain the reduction without the damage to femoral head. The damage, that is the avascular necrosis, is very very common when you are treating this DDH or dislocation of the hip, of the congenital variety or a developmental variety of the hip. Then you have got two methods of treatment, and one is the closed reduction and another is open reduction. The problem is the risk of the avascular necrosis. The growth potential of the acetabulum declines with the age, and hence the remodeling potential is more dependent. Then what are the risk of the avascular necrosis? 30% without traction. If you don't do the traction, 30% still can go into avascular. 15% with the reduction traction, and more than 5% in the human position with the flexion 90 degree and mild abduction and with external rotation. Then in certain cases, there is a need for open reduction. And the portable home traction is also available, as you can see in the this photographs. This one is the child is given the branch traction with the skin straps below the knee, and the hip are in abduction and 90-degree of flexion, and a weight is given over the head, and is a branch traction. And this is a close reduction, and then the gentle positioning is important because it should be in a safer zone, and at the same time the stability should be maintained. So abduction and internal rotation is important factors for the maintenance of the vascularity. Then adaptive genotomy increases the zone of safety by allowing the wider range of abduction, because by the age of 18 months, child develops the adductor tightening or the adductor tendons, they are contractured, and you may have to do a percutaneous adaptive genotomy at the inguinal region on the medial side under the GA, and it with a blunt knife, just with the palpation, you can do the adductor And in certain cases, you can do the hip spiker treatment. So as to, and this is a very comfortable position. The child can sit into 90-90 position, and this is called the pantaloon cast, in which you can use or reduce the you can maintain the reduction of the hip joint. Then there is another variety of the hip spiker in which the 90-90 is not done, but it is just 30-degree and abduction of 30-degree and external rotation of some 30 degrees. So in this the intraoperative radiograph is taken and the reduction is confirmed through the USG or through the CT scan. MRI reduction and vascular state of the head can be both used if you are using the hip spiker. Then you have to remove the cast after 6 weeks under the anesthesia, assess the stability through the moderate range of the motion, and do not try to dislocate the already reduced as hip joint. So X-ray epi pelvis to confirm the reduction and reapply the second cast for another 6 weeks, because by 6 weeks a child's nursing of the perineum can also soil the cast and may have a bad smell or the hygiene is not maintained. So you have to change it, but it should be done carefully so not to re-dislocate the hip, and this should be confirmed on the image or through the USG. And the third cast is used by abduction splinting, and usually they apply it for 6 or more weeks and then discontinue the immobilization. Then there is the obstruction to the reduction. The transverse acetabular ligament is one. Then you have got the pulvinar, you have got inverted limbus, you have got a thickened ligamentum teres, then you have got a iliopsoas tendon which is coming in way because it attached to the lesser trochanter and has got pressure on the capsule, and because of this pressure the capsule goes into a dumbbell shape constriction at the vertex or at the apex of the head of the femur. So extra-articular obstructions are the iliopsoas tendon, the adductors. Then intra-articular obstructions are inverted limbus or the inverted hypertrophic labrum. Then you have a transverse acetabular ligament, which are thickened. Then you have got a hyperplastic pulvinar, the ligament teres hypertrophy. Then you have got a constricted endomedial capsule, which is seen in the late cases. Then you have got neolimbus is not an obstacle to reduction and that represents the epiphyseal cartilage that must not be removed as this impairs the acetabular development. Then in certain cases, you may not be able to achieve the close reduction and the genesthesia, and you will not be able to put the head of the femur. And in those cases which are unstable hips and the widened joint space, the approach may be a medial approach or an anterior approach, but you have to cut the capsule and put the head inside the capsule. And in certain cases, you are able to do a good nature of capsulorrhaphy, and there is a repair and the overlapping, the relaxed or the overlapping capsule can be tied together and a capsulorrhaphy can be done so as to avoid the recurrence of the problem. And anterolateral approach is better when the child is less than 1 year of age, and anterior approach is better when the child is older. Then certain things more can be done to maintain the reduction, and there is the open reduction and the femoral shortening can be done if there is excessive pressure of the femoral head. When it is reduced, that may lead to the pressure necrosis or the avascular necrosis, and hence the pressure should be reduced by shortening of the femur. And in this, to the another point of doing an osteotomy of the femur is the reduction of the pressure inside the bone. The intra-osteal pressure is reduced, and hence the avascular necrosis is reduced. You are reducing the length of the femur, and at the same time you are correcting the excessive anteversion of the femoral head. And this can be done by trochanteric or subtrochanteric osteotomy, and then by using a small mini plate and keeping the osteotomy in a good position. Then you have certain other uh, options to correct the problem by doing an innominate osteotomy if there is need for the coverage of the acetabulum. If if the head is not covered with the acetabulum, it will go into decaying or into the degenerative changes of the joint. Hip is in extension and neutral position and is abducted. If more than 30% head is visible from the innominate bone, then osteotomy of the innominate bone is important so as to give rise to the coverage of the head through the acetabulum. Innominate osteotomy in more than 18 months of age are two kinds, are Salter and a Pemberton. Then you have to consider femoral shortening for excessive pressure on the head. Then 18 to 36 months of age, evaluate the stability of the hip during the open reduction, assess the need for the added coverage. Salter, Pemberton, pelvic osteotomy are famous or more routinely done than any other one. For children more than 3 years of age, usually an acetabular procedure is needed to cover the femoral head adequately. So these are the various derotational osteotomy to keep the head within the acetabulum. Then you have got 3 to 8 years of age treatment. The proximal head location, contracted muscles are dealt. The femoral shortening is required. Great shortening required for the higher dislocations. When the head has gone much higher, then you have got primary acetabular repositioning osteotomy often needed, and those are including this group are the Salter and Pemberton osteotomy of the innominate bone. Then in a 3 or more years of child, an acetabular procedure needed to be adequately cover the head is done to cover the head. Then polyostomy is simple osteotomy that reposition the acetabulum. Then your complex osteotomies that reposition the acetabulum. And then you have got a spherical osteotomy. Then you have osteotomies that augment the acetabulum. So these are the different varieties of the pelvic osteotomies. Okay. So then you have got shoulder innominate osteotomy. In this also, failure of the acetabulum index to improve within the 2 years of the reduction, then the persistent dysplasia after 2 years of age. The likelihood of the degenerative osteoarthritis of the thigh for 2 to 9 years of age, more than 2 years, not enough iliac wings that are thick enough to support the bone graft. Hence, more than 9 years, acetabular fragment not adequately mobilized and improve the acetabular index by average of 10 degrees. Then these are salt innominate osteotomy. These are the pictures. Then you have got tempered anatomy and improves the anterolateral coverage of the femoral head and stable osteotomy, and it does not require the internal fixation. Then hinges through the thyroid cartilage and reduces but it reduces the volume of the acetabulum and deepens the cavity, contraindicated if the acetabulum is small and relative to the femoral head. The size should be there to cover the head. Then the complications of the tempered anatomy are osteotomy or acetobuloplasty are closure of the thyroid cartilage, so very, very important, but it occurs very rarely. Then the damage to the acetabular growth increases if the osteotomy is too close to the acetabulum. It should be away from the acetabulum so that the thyroid cartilage is not damaged and the growth of the acetabulum is not hampered. And the pampered acetabuloplasty are seen in this picture, and you can see how they are done. Then you have got Degas osteotomy is very, very important and is done. It increases the acetabular coverage anteriorly, centrally, and posteriorly. Then placement of the wedge determines the areas of the coverage to be improved. These are of very less important to the UG standards. Residual acetabular dysplasia on the right side. Then you have got the steel triple osteotomy. And then very good, yes, the cherry osteotomy is also very important, and it is used when the other procedure cannot achieve a concentric reduction. Then you have got a contralateral fracture through the ilium with medial displacement of the acetabulum. The fragment and the intact hip capsule under the ilium. Over the time, the hip capsule converts into the fibrocartilage and becomes the new acetabular coverage. As it is a kind of a salvage surgery, and there's the same Chiari's osteotomy, the extra or the self of the bone is fixed with the screw. Then your Stylis acetabular augmentation program, and then more than 8 years of age, we have got certain other features, and that if the femoral head cannot be repositioned distally to the level of the acetabulum, then you have to do a palliative salvage surgery, but shortening plus pelvic osteotomy can also be done, but it is rarely needed. Then you have got degenerative arthritic painful hip, and in that case, the total hip is the answer. And the role of the arthrodesis, it is rarely used nowadays for the old unreduced dislocations, as a THR or total hip replacement orthoplasties are better options. And it is contraindicated in the case of the bilateral dislocations. Then you have got bilateral dislocations, you should leave it as it is, and later on you should do the total hip replacement. then a reduced hip but painful acetabular dysplasia, then you have to do a pelvic acetabuloplasty. Then the complications are the avascular necrosis of the hip, trochanteric growth is overgrowth of the trochanter, inadequate reduction, and the redislocation can occur. Then you have got a residual acetabular dysplasia, you have not corrected to the 100%. Then you have got acetabular dysplasia, which is presenting later on after you have done the surgery. And our necrosis can look like this in this picture. On the left side, on the right side, then there's a child which is smiling after putting the Paulic harness. Thank you very much for a patient listening. We'll be back after some time in the next lecture with another very important topic of the hip and the Perthes disease. Thank you very much.